Thank y'all so much for coming. Like I said, it's really fun to come back here, and I hope to um, engage more with the School of Public Health. I've only been on faculty for 3 years now after finishing training, and I'm developing more and more relationships. So please feel free to reach out. I'll have all my contact information at the end of the slide. I have no conflicts of interest. I was going to disclose that I have a whole bunch of gory slides from surgery in this talk, but then I was also going to share that it was April Fool's Day and only have one of those slides. So, all right. So as was mentioned during my training, the School of Public Health meant a lot to me. In the middle of surgical training, we have this opportunity to do academic development time under 232s, and it's almost 75% of our surgical residents will come out and do surgical research. And that's what I did. And back in 2014, 2016, Meredith Kildor was my mentor, and I still keep all my slides from all classes. I was actually talking, Hannah Ficarino is a student right now, going through the MSH program. She's one of my mentees, and she's in Dr. Sin's class, talking about empirical methods. I still have those slides from that class. It was great. So regardless, I went to Cleveland for 1 year, been back at UAB. I'm from Dothan, Alabama. So it's fun to take care of problems that touch base to my hometown. All right, the one gory slide. This picture sort of embodies how I got into this subject. While I was at Cleveland, at the Cleveland Clinic, Dr. James Church was one of my mentors there, and he is a world-renowned colorectal surgeon that runs one of the largest hereditary colorectal registries around. And it was really cool to be a part of that because people would fly in from all over the nation to get their screening, to get their family members tested, to get their prophylactic surgeries. And one day during clinic, Dr. Church went up to me and asked, do you have any interest in hereditary cancer genetics? And I promptly said, absolutely not. I was into more outcomes research, surgical readmissions, and while I enjoyed doing these surgeries, it wasn't really for me. Fast forward to my clinical practice, and this colon that you see on the screen is from a patient I had in my first year. He was 35 years old, and he was from rural Alabama. He had presented to an ER with abdominal pain. They suggest he had diverticulitis. Eventually came to see me, and about a week before he saw me, they had an attempt at a colonoscopy. It showed that he had thousands of polyps throughout his colon, and he had a colon cancer in this descending colon on this left side. They biopsied it, proved it, and when he came to see me, we were highly suspicious that he had a hereditary colorectal cancer syndrome, a polyposis syndrome, specifically familial adenomatous polyposis syndrome. And we did genetic testing and confirmed that for him. He had this mutation, the APC gene. This gentleman ultimately had to have an urgent surgery to remove his colon because this cancer began obstructing. He had to have chemotherapy. And the one thing that struck me was in clinic, when I was there, his father was also there. His father looked up to me and said, you know what? When I was young, I'd have my colon taken out. Is there any way I could have passed this on to my son? And it was at that moment that I felt that like this immense sense of lost opportunity, like something could have been prevented right here if I had diagnosed this child. Typically in familial adenomatous polyposis, patients have a 100% lifetime risk of colorectal cancer, and it typically occurs by about age 35 when this guy presented. We typically begin screening around age 12. People have a prophylactic colectomy, removing their whole colon and rectum by age 20 in their early 20s. So I really felt there was something we could do. And it made me wonder how much cancer morbidity or mortality is associated with missed opportunities in hereditary colorectal cancer syndromes. Just to step back for colorectal cancer, for those who are not as familiar, this is the third highest incident cancer in males and in females, and third highest for cancer-related mortality. And more recently, you may have seen the news that it's becoming much more frequent in young adults. It's come to now the number one cause of cancer-related mortality for males less than the age of 50, between 20 and 49. As a surgeon, I think about colorectal cancer as either colon cancer or rectal cancer, because rectal cancer is treated differently, just because of its location. So I got a picture of a colon in here, and you can see that about 25 or a quarter of colorectal cancer is rectal cancer. But importantly for this talk, all of these cancers start in the same way, from the mucosa lining of the colon, where you start to develop this adenomatous tissue. You develop an adenoma polyp, which gets these precancerous changes called dysplasia, that eventually begins to invade into the deeper layers, like the submucosa, into the muscle layers, and become cancer that can metastasize and cause havoc. This gives us an opportunity in colon cancer to prevent the development of colon cancer by endoscopically removing these polyps. So taking a lighted scope and a cleaned out colon to identify these polyps has been shown to reduce colorectal cancer risk. So we're coming off the eve of Colorectal Cancer Awareness Month. Hopefully y'all saw something related to this in your daily lives. We had a big awareness program here at UAB to encourage patients to think about screening. The age dropped from 50 down to 45 just a few years ago. And we've tried to promote awareness around UAB and our satellite sites. But back to hereditary colorectal cancer syndromes. This talk is not going to be like a laundry list of all the syndromes, but I'm going to give you a glimpse of some of them. The most common that you're going to hear about are going to be related to Lynch syndrome, or hereditary non-polyposis colorectal cancer syndrome, related to these genes, MLH1, MSH2, MSH6, PMS2, EpCAM. These are all mismatch repair protein genes. So when DNA is replicating, you can have these proteins that go back and make sure the editing was correct. And if these mutations or mutations in that editor protein happen, you can have more defects in your protein, leading to cancer. Each of these genes has its own cancer risk. So lifetime risk of colorectal cancer can be up to 80%, really, with the MSH6 protein, but it varies. There's other cancers like ovarian, endometrial, uroepithelial, bladder cancer that are associated with Lynch syndrome. But today we'll focus on colorectal cancer. I mentioned polyposis syndrome. So like that guy that had like thousands of polyps in his colon, that was familial adenomatous polyposis. We talked about that in the APC gene. Then there's MUT-YH polyposis, MAP, the only autosomal recessive syndrome you see here, associated with 80% colorectal cancer risk. And then you have these harmatomatous syndromes. They're not adenomatous polyps. They're typically a more benign polyp, but still have a significantly higher rate of colorectal cancer, Peutz-Jeghers, or juvenile polyposis. There are more. These are sampling of some of the most high frequency colorectal cancer syndromes. So what are we talking about when we're saying improved hereditary colorectal cancer outcomes? So here's the mental model that we identify patients through testing. Once we know about those patients, then we can do screening or prophylactic interventions. So like for Lynch syndrome, you start screening at age 25. Every 1 to 2 years, you're doing upper and lower endoscopies. They may have prophylactic removal of their ovary or uterus at some point later in their life. And the whole goal is to reduce cancer incidence, morbidity, and mortality. Now, this really gets amplified when you can find family members that may be affected and test them also. That's where you get into the real cost effectiveness of all this genetic testing. But today, we're going to focus on the first part, identifying patients. So most of you are probably begging the question, like, how many patients have hereditary colorectal cancer syndromes that have colorectal cancer? So to do that, you would have to do genetic testing on everyone. And there's just now some studies coming out that do just that. This one's out of Mayo, out of their several hospital system, where they use an 80 gene panel. It's a pretty big genetic panel on all their colorectal cancer patients. And what do they find? So in these 361 patients, 38% negative. 46% have this VUS, or variant of unknown significance, meaning it's different, but we don't know if it's pathologic or it causes problems. And then we have this group of 15% of people who have positive findings, known pathogenic mutations, but they have variable penetrance, as you see here, high, moderate, low. They're putting Lynch syndrome as high penetrance category here. But the studies across the literature vary. They're going to report 7 to 15% of people with the colorectal cancer have pathogenic variant. This matters their gene panel, their population. But we do know that people with less than 50, so in this study, 20% of patients that were age less than 50 with colorectal cancer had a pathogenic variant. So they're a high-risk group. So what are the indications currently? We really look to the NCCN to guide this. Really, insurance companies look to the NCCN to guide this. And these are the criteria that are out there. Age less than 50 makes sense. If you have a personal history of like another colorectal cancer or other Lynch syndrome related cancers, makes sense. Strong family history. If you have a whole bunch of polyps, not maybe a polyposis syndrome, or if you have a tumor MMR deficiency or MSI high tumor. I'll explain that because it's sort of important. It's been in the lay press. You may encounter it. So what is tumor testing? So this is like if I see a cancer and I take a biopsy on a colonoscopy, they can do staining, immunohistochemistry, and look for the presence of these proteins and say they're deficient or not. Or they can look at microsatellite instability, the downstream effect of lack of function of one of these proteins to see if it suggests that you're lacking a protein. This has become really important because this study in New England Journal from 2 years ago that showed that PD-1 or MMR deficient tumors were extremely sensitive to PD-1 inhibitors, these new immunotherapy drugs you hear out. I mean, and this is a case series from New England Journal, but 12 patients had 100% complete response. It's changed the guidelines of how we treat these patients. So it's really expected that we test this in all colorectal cancers now to guide their treatment. But back to this tumor testing and talking about germline testing. So realize that this is tumor testing, and tumors develop mutations and thus develop a cancer. So this is not a germline test. So if you have MMR deficiency on a tumor, it suggests you may have Lynch syndrome, but it doesn't show that. You really got to go get your blood drawn or saliva taken to get the true DNA tested. And these things are imperfect. I mean, MMR is immunohistochemistry, so you can see the variability in staining. Some of you may do staining and see how variable it can be. And same, MSI is not perfectly sensitive for patients with genetic germline mutations. So, a few issues with our current NCCN guidelines. One is that back in that study where they tested 100% of patients, there was a quarter of patients that had a pathogenic variant that did not meet criteria. So we're missing a fair number of people by these strict criteria. Half of the patients with a pathogenic variant didn't have a first-degree relative with family colorectal cancer or Lynch syndrome related history. And then we talked about MMR and MSI testing being imperfect. And as a physician, this is also complicated. There's another list of things I got to memorize. What else could we do better? So genetic testings overall for many cancers are growing. Universal germline testing, where everybody's supposed to get testing, is currently recommended for pancreatic, epithelial ovarian cancer, as well as metastatic prostate cancer. And here's a glimpse at what the guidelines look like on the website for colorectal cancer. There's a recent update. So you got, they less than 50, get tested. Do they have a known MMR deficiency? Yes, get germline testing. But look at this, no MMR deficiency, not less than 50, consider germline testing. You know, it's interesting words by a massive committee who has huge implications for patients. And so the Collaborative Group of America's Inherited Gastrointestinal Cancers group is probably the biggest group in the US that looks at these types of guidelines, and it just meets and discusses research related to these hereditary syndromes. So what are the pros and cons? We had this debate at our most recent meeting. Pros would be we're going to capture another 25% of patients, and it makes everything simple. I just test everybody. Cons, often the genetic testing doesn't inform treatment, and some of the pathogenic variants are lacking management recommendations. So I had a patient recently see me for a CHEK2 mutation, something that's associated with breast cancer. So I've referred them to the high-risk breast cancer clinic, but we don't really have strong epidemiological studies to suggest its association with colorectal cancer. Many variants of unknown significance will be identified. So yes, we're going to add stress to patients, but the counter argument is going to be that we're going to figure out what these variants really mean if we test everyone. And then lastly, the capacity issue. You got 101.5 million colorectal cancer survivors. What do we do with all them? Or are we going to overload our genetic counselors that are already backed up with patients? So this is still being debated. We'll see what happens in the next few years. The question remained for a long time about what are current genetic testing rates. And believe it or not, there's not a great administrative or good database out there to answer this question. So this was a group out of both Georgia and California that said, well, we got to create that database. So they merged SEER and state cancer-related registry data with the data from 4 of genetic testing companies that do like 95% of the testing for United States patients. And these are the numbers they reported. This was published just last year. So overall rate, when they looked at all cancers, was 6.8% were having some form of genetic testing. This is higher for some cancers associated with strong hereditary risk, like male breast cancer, really associated with BRCA. Ovarian, we mentioned the universal recommendation there, female breast, and then it drops off. Look at pancreatic and prostate cancer, where you're seeing universal testing. And then colorectal cancer, only 5.6% of patients with that diagnosis in those states were getting genetic testing. Now, this is even more interesting. So this is actually looking at the subset of those lower testing groups, so not the male breast or ovarian, but looking like what's happening over time. So yes, testing rates are increasing, but when you look at it by race, you're really starting to see the divide. So for me, I mean, this is an inequity being created as we go forward. Unless we do something about it, it will certainly be exacerbated. So what about at UAB? This is where I reached out to some of our medical students and Dr. Ficarino to help out. And we decided, well, why don't we look at people where it's 100% recommended for age less than 50? And we found 100 patients at UAB over the sequence of several years and found about a third are getting tested. A little bit higher than that are going to see a genetic counselor, but most people that see a genetic counselor are getting tested. And when you look at factors associated with genetic testing here, we're seeing family cancer history and chemotherapy. So what does that mean? So it means that if you're as a patient, you're probably worried, or as a physician, referring to a genetic counselor, you're worried, again, being linked to cancer history. But remember, cancer history, you have de novo mutations, and there's a whole bunch of people without a family cancer history who have these mutations. And then lastly, the chemotherapy probably implies that they're seeing an oncologist. There's certain practice patterns that are being followed that may be modified. We also looked at like what's happening with our genetic counseling here at UAB. So we just looked at genetic counseling logs and to see who completed genetic testing. So again, if you see a genetic counselor, you're very likely to have genetic testing. So 85% of patients completing testing. And when we try to understand like what factors are associated with testing, being female, you're more likely to be tested, but also where you were seen, which was interesting for us. So if you were seen by a genetic counselor in the surgery clinic simultaneous with your other diagnoses, which seems convenient, you're actually less likely to get tested than if you came and saw them here in the genetics office. Obviously you can break that down a whole lot of why that might be happening, but it does suggest that setting matters. And then when we also looked at like who didn't get tested, they were from all over Alabama. So it tells us if we're going to start thinking about any interventions, we've got to be sensitive to the setting and to rural populations. And then lastly, this is another medical student who looked at like, why are people refusing? Genetic counselors write really nice notes to understand. And so we can see if people do refuse, why. He found that over half the refusals were actually active refusals, which is interesting. And then a fair number of those were due to low perceived risk. Some were due to life and disability insurance coverage. So with genetic testing, the genetic GINA, the Genetic Non-Discriminatory Act, protects you in terms of health insurance, but you can still have changes in your life or disability insurance with genetic testing, which is important. So summary so far, we have expanding indications. Testing rates are currently poor. There's inequities that exist for disadvantaged populations. So we're going to have this exacerbation of cancer morbidity if we do ever go to universal testing. So in grant language, there's a critical need to implement interventions to improve genetic testings for diverse patients. So where do you target these interventions? Where's the breakdown? And if you look at genetic testing right now, you may look at it like chronologically. You got to identify patients, you got to refer them, they got to see a genetic counselor, and then they got to get tested. So, and there's barriers in each of these, the guidelines, family history, provider behaviors, referral processes, making genetic counselors available, telehealth, looking at perceived risk, helping out with transportation or insurance barriers, or looking at other clinic processes and helping with costs. And there have been interventions at each of these phases, like, like sort of like pistols, like sharpen each one, but like what's like a multi-level intervention where we could actually flip this on its head? And that's emerged, and it's an alternative care model for genetic testing called mainstream genetic testing, which, as I mentioned, the traditional pathway, I would refer, there's a patient that may need it. I'm going to send them to genetics. They're going to go see a genetic counselor and get tested. And this mainstream genetic testing, the responsibility would be on me to identify eligible patients, test those patients, and then if they're positive, then I'll send them to a genetic counselor. If they're negative, I won't. So this has been evaluated for other cancer types. In pancreatic cancer, it's been shown to increase testing 6-fold for germline testing. They've asked patients, and with prostate cancer, are they satisfied? They're like, yes, that's great. I get to leave clinic and not have to see another person. And in ovarian cancer, they're able to significantly increase rates as well. In the Netherlands, where they calculate all their costs, they reduce costs by reducing genetic counselor visits. So what other data do we have to support this? This was a cool study out of MD Anderson, with also a cool acronym, Making Genetic Testing Accessible trial, where they identified patients that were at risk for ovarian or breast cancer related syndromes, a whole bunch of patients, and then randomized them to 4 arms. And the 4 arms were whether they had pre-test counseling, genetic counselor, yes or no, and whether they received post-test counseling, yes or no. All patients that were identified to have a pathogenic variant went on to get see a genetic counselor, of course, but those are the arms. Their primary outcome was like distress, because that's the worry, right? If I'm not taking them to a genetic counselor, am I gonna like totally bombard these people and ruin their lives by the distress we put them in? And there's a non-inferiority study here. The 2 arms, no pretest genetic counseling, were A and B, and so no difference in distress. I think it's 3 months. But the other interesting secondary outcome was completion rates were slightly higher for these non-pretest arms, or non-pretest genetic counseling arms. So suggests that, yes, we can do this and patients won't be distressed at least. So this gets on to sort of my research goal of how do we increase uptake of this intervention in colorectal cancer. And the work that we're proposing right now is to better identify barriers from multi-levels, from providers, stakeholders, colorectal institutional stakeholders like clinic nurses and managers, and then colorectal cancer patients. And then how can we take those barriers to take proven implementation strategies and adapt them to those barriers? How can we pilot this and understand certain implementation outcomes, and then ultimately run trials for that? This is a K that we're waiting for summary statements on right now, and in the future are hopefully down the road. But before doing all this research, I realized in my practice, I should probably start doing mainstream genetic testing myself. And that will help inform exactly how we design all of this. So I've partnered here with Alexis Heatherly and Catherine Smith, who do the majority of our GI cancer genetic counseling, and we really came up with these 5 things that we thought would be important for physicians to know to do mainstream genetic testing. So identify patients, have the pre-test discussion, select right gene panels, facilitate collaborative collection, and post-test follow-up. So I'll just briefly walk through these. Identification of patients. So what's inevitably happening in my clinic is I'm picking the low-hanging fruit. So the very obvious patients, those less than 50, or those with extremely strong family history. And when I get people that have like a history of breast cancer, prostate cancer, and brain cancer, and I can't even think of like all the different genetic syndromes, then I send them over to Alexis and Catherine for more detailed discussions. But I've worked with Ambry Genetics too on this, and they've provided some easy things to hand to patients to identify who needs the testing when they walk in their clinic. But it's been relatively straightforward to identify patients. Pre-test discussion. This is what I was most personally distressed about. Like, how can I have this discussion? I'm not a genetic counselor. And by sitting down with Catherine and Alexis, we came up with these 4 core categories of what had to be in those discussions. One was like, why are we doing the testing? Like, what does it mean? And what are we going to test? And importantly, we had to talk about what are those test results? What could it be? They're going to be negative, positive. We have this variant that we don't know. We have to follow you, and we can call you over time if it changes. And also tell them that if you test positive, we hope that you would tell all of your family members, because that is where you can have a huge impact. We talk about privacy protections. I mentioned Gina earlier. We talked about disability and life insurance briefly. I tell them that, this is really the best form of life insurance for your family, know their cancer risk. And then costs have dramatically changed over the past 3 years for genetic testing. The spiel now is that nobody would ever pay over $200. The overwhelming vast majority, so like 90% of patients pay nothing because they meet criteria. And then if people have to pay over $100, the companies will actually call them and have a conversation if they want to proceed. And then they have a lot of coverage options too. So it's been relatively straightforward. This sounds like a 20-30 minute conversation. For most patients, I've distilled it down to four and a half minutes in my clinic. So it's been very feasible for me to add on to a colorectal cancer discussion. Next was the lab collection, which next was the gene panel selection, which I was also worried about. And that was actually made easier by the genetic testing companies. They want this to be easy, right, for providers. So here's this example of some of their panels. They've nicely named them ColoNext, Cancer Next panels. These are a lot smaller than the 80 gene panels too that they were using that earlier study. These are 20 gene panels and 36 gene panels, which is, to be honest, I can, in this ColoNext, as a non-genetic counselor, I can tell you what most of these gene mutations imply. Now we get into like Cancer Next, like I don't know if I should be testing NF1 neurofibromatosis in like a colorectal cancer patient, but BRCA is included in there, yes, but not in the ColoNext and may have some certain implications. So this has been relatively simple. I've worked with other genetic testing companies like Myriad, and they have one panel for everybody, which makes it even easier. So, which does highlight the role of industry that we'll have to overcome as a barrier versus assistance in mainstream genetic testing. Facilitating lab collection. This was actually the thing that I found the most burdensome. So this is not like I collect like a normal, CEA marker or blood draw in the clinic. We have to click a specialized blood draw. We have to hand this box to the patient. They have to take it to Kirkland Clinic Pharmacy or to the lab, get their labs drawn, and then Ambry's made it as easy as possible for us. They give us prepaid FedEx things, but we have to go pick it up and get it to a FedEx box. And that is a barrier that's going to be one of those institutional barriers that we have to overcome and will be unique to each and every health system. So, and then lastly, the post-test follow-up. Let's see this before. Ambry has very nicely given you access to this Ambry report, and all the companies have a portal like this. We've been able to get it where it's shared with your genetic counselor. So I get a report saying something's positive, I just clue them in for post-test follow-up. And I'll show you a few examples. This was a 18-year-old from Montgomery, Alabama, who came from a very disadvantaged family. Her mother had died at age 30 from some GI cancer. We don't know what type. And when she came up to see me, she had to get like some relative, distant cousin to get her a ride up here. And I knew I had one chance to get genetic testing done. There's no ability. I don't even know I can mail anything to her. But we were able to have her go by the lab and stop her genetic testing, identify Lynch syndrome with this MLH1 gene for her. And she was there with her 3 sisters. And I was able to tell them, like, we're going to get this done. We're going to be able to tell y'all. And so to me, that was very impactful. This is an example of just another lady she had 46, she had metastatic colorectal cancer. She's been involved with lots of services here at UAB, but every time we see her, we say, go get your genetic testing. And she just falls through the cracks constantly. So I finally got her in clinic one day. I was like, will you go to the lab today with your other labs and get this done? She said, yeah, sure. And she was able to complete her testing. Even though it was negative, we were able to tell her children also that this was not due to a known hereditary condition, to give them some relief and going forward, or information at least. So what type of barriers are we anticipating? As I mentioned, we're sort of bucketing them into different levels from clinicians or providers of, what are the barriers to identification, having that discussion, policy, and selecting panels. We mentioned about the institutional barriers, the lab collection, the follow-up, access to having genetic counselors. So I don't want to think about this just in terms of UAB, a big complex. I'm thinking about like in Dothan, Alabama, a small GI group or a small 2-surgeon clinic. How do they get access to genetic counselors? Because we only have them in Mobile and Huntsville and Birmingham in Alabama. And then for patients, like what do patients care about? Like do they enjoy this? The other side suggests that it is preferred. But like what knowledge do they want in that pretest discussion? What tools or aids can we provide to give that knowledge independent and decrease clinician error, and then help with costs? So we have currently selected or are proposing 3 implementation strategies that have been previously proven that we hope to modify to the needs of colorectal cancer patients and providers. So improving colorectal cancer outcomes, I mentioned this is just like the first step, right? How do we identify these patients better? And there's a whole stream of research to come from this. We really hope to get into understanding how do we get screening and prophylactic interventions done in a timely manner? How do we facilitate familial cascade testing? And so we've received some funds from the UAB and General Endowment Fund to develop a registry here, which is harder than it sounds to me, but it's coming off the ground soon, to where we can track these patients, do annual surveys, understand where they are on their screening, so that we can better improve their cancer outcomes for them and their family members. So with this, this work is like a whole team of people. I mentioned the genetic counselors, some of our surgery members, Hannah Ficarino, Mary Smith, and Sushant Reddy, some other medical students, and then a mentor team with Smita, Dan, Wendy, Lisa, Joshua, and Samir Gupta's out in San Diego. So with that, I know I run a little early on these talks that talk fast, but I'm so happy to share this. And these are all my contact information. Feel free to reach out anytime if you have any interest in this area. So thank you.